Thank you. It's wonderful to see all of you here. Excellencies, distinguished guests, colleagues, and friends. It's my pleasure to welcome you to the launch event for the Lancet series on universal health coverage. I know that there are many, many interesting and important events this week, so on behalf of the Rockefeller Foundation and our very distinguished co-hosts, the Lancet and Results for Development, I want to thank you for making this one a priority. I also want to give my special thanks to my colleagues from the Rockefeller Foundation for all of the hard work that they've put into this event and so many events this week that relate to this aspiration of universal health coverage. The individuals and institutions in this room represent some of the best minds and advocates for the expansion of universal health coverage. And as the discussions on the post-MDGs are beginning to heat up, it is really, I think, a critical moment for global health. It is possible, at least it's being discussed as possible, that in the next round of Sustainable Development Goals, there will only be room for one health goal. At the Rockefeller Foundation, we firmly believe that this should be universal health coverage. Today, more than 150 million people worldwide face catastrophic healthcare expenditures, and those costs push 25 million households into poverty every year. Billions of people still finance their health care through out-of-pocket payments, leading many to forego health care or to use school fees to cover medical costs. But it's not just about finances, it's also about health. As one of the papers in this series suggests, the evidence is building that progress towards universal health coverage results in substantial improvements in population health. And as the WHO Commission on Macroeconomics and Health documented more than 10 years ago now, better health clearly contributes to more equitable economic growth. So we have a completely virtuous circle if we can get this going. People who are ill and otherwise unable to work can be pushed into poverty, and those who can work and earn a living are lifted out. Healthy children are better able to learn and become more productive adults, and healthier people are better able to withstand shocks and stresses, making entire societies more resilient. Universal health coverage is an accelerator that reduces tremendous financial and social burdens. It has the power to transform families and communities and societies, indeed even economies. The economies of developing countries are projected to grow faster than those in the developed world in coming years. And those countries will increase the amount they will spend on health care. How can we ensure that these increases are well spent, that they lead to more equitable access to affordable and quality health care? We know that focusing exclusively on financing reforms will not be enough. Improving health resources and scaling up specific health services are also essential. That's why we at the Rockefeller Foundation are working with so many of you as partners, so many governments, to secure the technology, the talent, the tools, and the training to become more effective in transforming health systems. In Rwanda, we're working closely with the Ministry of Health to develop their national E and M health plans and strategies, ensuring that the system is interoperable and that all efforts are well guided and aligned with their national priorities. In Bangladesh, we've been encouraged by the Prime Minister's commitment to universal health coverage. And we've been investing in innovative programs with organizations like BRAC, the world's largest NGO, to test ways to extend coverage to groups in Bangladesh excluded currently from the health system. Regionally, we're facilitating South-South learning through a joint learning network on universal health coverage. Vice Minister Gufran's been a founder and mentor and an active participant from the beginning. Health officials from Ghana and Vietnam, India and Indonesia, Thailand and Nigeria, among others, have been working together to exchange great ideas about best practices and new strategies, and to focus on the reforms necessary for universal health coverage. Globally, we were an early and very proud supporter of the landmark 2010 WHO World Health Report on universal health coverage. And we're now providing support to WHO to ensure that the world has a robust system in place for measuring and monitoring universal health coverage at the national level. So what's next? Well, we hope that it's a UN resolution on universal health coverage at the General Assembly next year or the year after that acts as a stepping stone to embed universal health coverage firmly within the post-MDG framework. Over the course of our 100-year history, and it will be 100 years next year, the Rockefeller Foundation has collaborated with leading experts and national and international organizations to overcome previous global health challenges like hookworm and yellow fever. We see universal health coverage as another link in the chain of our proud history, and we ask you to join us. We hope that you will support member states through the UN to build momentum for this proposed resolution as a way to communicate the ethical imperative, the financial feasibility, and the political willingness of governments to work towards universal health coverage as a vehicle to improve health and to reduce poverty. As with any bold movement, we understand that there may be some skepticism. There are doubters who say that universal health coverage is too expensive or not politically possible. But armed with the success stories from tonight's panelists and from this exciting Lancet series on universal health coverage, we intend to prove them wrong. The fact that the Lancet, the world's preeminent journal in global health, has put together this series speaks to the importance of universal health coverage. I'd like to thank Richard Horton and his colleagues and David DeFerranti for your leadership on this landmark series. And now, I have the very great pleasure of introducing Director General of the World Health Organization, Dr. Margaret Chan. Of course, to this audience, Margaret needs no introduction. She's a tremendous champion for progress on so many global health issues, and she is a leading voice, the leading voice, for universal health coverage. I also know that she is in very high demand this week. So on behalf of our co-hosts, let me thank her for taking time and for launching this important evening discussion. Margaret?
Thank you. Thank you so very much, Judith. Thank you for your leadership, in Rockefeller Foundation. I was going to sit down and talk, but I think I better stand up because I'm so short. and Sheikh tonight is not here to lift me up. For those of you who were speculating whether that was in the script or I was taken by surprise, it's the latter. Because perhaps I was wrong in doing a trick on him because he is so tall. And then when I walk on the stage thanking him for the introduction, I was kneeling down. And he said, I have to pick you up. But, Judith, jokes aside, I had to send an email along with the photographer, which is going a little bit wide in my organization. I don't know whether it has gone viral or not. To explain to my husband and my son, the two men in my life, most important men, what is going on. So friends, colleagues, excellencies, jokes aside, Judith, no matter how busy I am, this is not one of those meetings I would miss. Because I want to come here and personally thank all the people behind the scene working for a long, long time on this very important subject. And of course, the Rockefeller Foundation, your good self as the president of the foundation, is a leading light in this. David, I still remember you, myself, and a few, how should I call, the activists on universal health coverage. We met in the margin of a meeting, and we were conspiring and asking ourselves the question, how important is this going forward? And at that time, people may think that, do you think she's on board or she's not on board? I believe in life, there is a time for everything. And I need to pave the steps and the way to gain what I call broad-based support for a movement. For those of you who work in UN, you know how interesting and complex it is. With 194 bosses, I think I can trump any one of you here. It's not easy to get the kind of, support. But I have to say, many organizations, of course, the results for Development Institute, and of course the Lancet and others led the way. And actually we are taking inspiration from you. We're listening to you, to civil society groups, to important foundations, to member states like Thailand, Indonesia, the group of countries that call themselves pushing for the foreign policy and the intersection of global health. They've been, talking about this, and they are actually the group of countries. France was there, Senegal was there, Norway, and they are there to really push this. And, Judith, you refer to the possible UN resolution, and this is a group of countries who want to give this important subject its attention and at a very important fora. Without preempting what would be the outcome, and as you quite rightly put it, for those of us who are passionate about this issue, we need to lend our weight to support it. Now, that is off the cuff, without following script. I think I better go back to my script now. Let me take this opportunity to say how delighted I am to participate in this launch on the Lancet series on universal health coverage. I thank the Lancet, but I'm a bit disappointed that Richard is not here. I thought he was going to be here. I met him this morning, right? But no, he's a good friend. I know he has to go back to his lover, right? So I want to thank the Lancet. What did I say wrong? But anyways, I thank the Lancet. I thought I just add, to lighten up the meeting a bit. Sometimes, the UN meetings can get to be quite heavy and serious. I thank the Lancet and the Results for Development Institute for undertaking this initiative, and of course the Rockefeller Foundation, and Judith, your good self, for supporting it and hosting this event. As we know from past experience, these Lancet series can have a remarkable impact on public health thinking and practice. By looking at an issue from multiple perspectives with multiple sets of evidence, they can redefine the scene. They can sharpen the issue, inspire action, and also pinpoint those actions that are most likely to bring results. In other words, they tell us where we stand and how we might move forward. The interest in universal health coverage is definitely there. Since the publication of the 2010 World Health Report on health system financing, thanks to your support, in fact, now the last count is more than 70 developing countries. I want to emphasize, middle income and low income countries have requested WHO technical support for their plans to move towards universal health coverage. Let me quote Thailand. Thailand says you don't have to be rich to start thinking, planning, and moving towards universal health coverage. And I was really touched that so many countries wanted to do it because it's the right thing to do. It's the most equitable thing to do. The Lancet papers published to date present evidence showing the positive impact of universal coverage on health outcomes. They explore the transition to universal coverage in its political and economic dimensions, and other lessons about how health financing reforms in countries have been enacted and, as I said, in many low-income countries, and bringing results. The results are improvement in people's life, saving lives, not only that, protecting people from bankrupting their domestic account. We call it catastrophic expenditure. WHO studies show that every year, and I'm underlying, every year, 100 million people were pushed into poverty because of rising healthcare costs. I personally visited a family in Bangladesh. A woman told me she had to sell the cow, which is very dear to her, to pay for hospital fees. And the cow is dear to her for two reasons. She milked the cow and used the milk to feed her children. And the surplus, she could sell them and bring in an income. Because of illness, she had to sell the cow, so that means she has nothing. No cow, no milk for the children, and no income. So that's why I think we all should lend our weight behind this important subject. Now, comments from the Lancet series also offer a big picture view of the historical significance of the evidence. And I want to thank all the authors for their contribution. And also it is extremely helpful to have a very respected economist, my friend Jeff Sachs. Jeff, you argue very strongly against what you call it, in quotation, lazy thinking. The lazy thinking is, it assumes that user fees will reduce overconsumption of health services or increase their value in the user's eyes. It's not true. User fees punish the poor. And if indeed we believe in development, if indeed we believe poverty reduction is the objective and the outcome of poverty, of development, if we cannot protect the poor, if the things that we are doing cannot reach the poor, we miss the point. Now here is another warning. Yes, health financing reforms are just one part of the whole picture. Health insurance raises public expectations. Once you raise public expectation, people expect ready access to medicines, to services, and they want quality service. A commitment to universal coverage means meeting these expectations as well. So we better get, both pillars right. The financing part of it and also the service provision part of it. My personal commitment is definitely high. I regard universal coverage as the single most powerful concept that public health has to offer. Let's move towards that direction. Please don't punish the poor with user pay, and don't disappoint them as well. Universal health coverage is also the best means to maintain or to cement the gains that we have collectively accomplished in the first decade of this century. It is a powerful social equalizer, and it is the ultimate expression of fairness. At a time, ladies and gentlemen, at a time when policies in so many other sectors are actually increasing social inequalities, I would be most delighted to see health lead the world towards greater fairness in ways that matter to each and every person on this planet. Let me once again thank you for your attention. I look forward to hearing your comments and also your advice. Thank you.
Before we go further, we really must recognize the wonderful contributions that these two remarkable, dynamic women who've just spoken and the institutions that they are leading and providing such tremendous leadership to have made to the issues we're talking about today. Margaret, think 5 years ago, we could not have had this discussion. And your leadership, and think of all the things that have been accomplished, including the World Health Report, that we really are very grateful to you for. And Judith, think of the wonderful contributions that the foundation has made. At a time 5 years ago when there was doubt, there was skepticism, there was dissension, the foundation has really paved the way and made it possible for so many wonderful contributions to make. And Judith, you have been personally at the forefront of all of that. So thank you. I only regret that I'm not able to lift both of you in the air. I actually think I could, but maybe I won't try. Before we turn to our distinguished panel, just a word or two about our authors, since they don't get to speak for themselves tonight. And we are, after all, launching their papers. So as you'll see, if you haven't already read them, we have a rich array of papers in this series. And one of them by Bill Savadoff, Amy Smith, and Victoria Fan. And Victoria's here, just raise your hand, good. Really explores the historical trajectory, considering the importance of political processes. By the way, that's another issue. 5 years ago, we might have had a discussion assuming that 90% of the discussion is about technical issues of how to design universal health coverage and 10% is about politics. Now we know it's all, or at least 90%, about finding a solution that can bring the various political forces together around something, an issue which in this country we're still working on. And in addition, that paper also brings out the importance of how income growth has an impact on health spending, and how the increase in pooled health funding is both cause and effect in paving the way. So that's one of the papers. A second paper by Rodrigo Moreno Serra and Peter Smith, and I think Peter is here today, or rather Rodrigo is here today, right there, really breaks new ground on the issue of whether all of this makes a difference for health. Now, it has other important benefits as well, such as financial protection. But the key question for a discussion like this one is, are those health benefits there? That has eluded previous researchers. Rodrigo and Peter have pinned that down, so thank you for that. And a third paper by Gina Lago-Marcino, Alice Garabrandt, Adikak Adyas from Indonesia, Nathaniel Atu from Ghana, and Richard Muga from Kenya. That alone takes up 20% of the paper right there, just saying all those things. Takes a fascinating look at 9 countries that are showing, well, in today's world, how are countries tackling these issues? We have examples from the past of countries that have moved towards universal health coverage. But what about lower middle and middle income countries, particularly low and lower middle? How are they doing? What are the issues they're coming up with? What are the patterns we see? And what does that tell us about the future? And Gina and Alice are here. If you could just raise your hand, that'd be great. Well, WHO and the Rockefeller Foundation have been crucial, as I said at the outset, and now it's great to have another terrific institution that is putting its weight behind it, and that's the Lancet, which has made possible this bringing together and spreading to the world and capturing the world's attention on these issues. So we're delighted to have Bill Summerskill here today, who actually deserves, don't tell Richard, more credit for all the work he did than Richard did in pulling it all together. And I'm going to let Bill explain where exactly is Richard now.
Right. Thank you, David. Madam Director General, Excellencies, distinguished guests, friends. The Lancet aims to publish material that will change thinking and clinical practice. By bringing together science, policy, and public health, today's series on universal health coverage represents as great a change to thinking and practice as any medicine or intervention. And so I thank the authors for their scholarly papers, because they validate the passion for universal health coverage that is shared by so many in this room and beyond. In preparing the series, I was struck by the observation that universal health coverage is a common vehicle to achieve the aspirations of so many different groups that each are striving to improve human dignity and development. Whether via child health, safe motherhood, the alleviation of poverty, women's rights, or economic development, to name but a few, all recognize the necessity of access to effective health care without fear of impoverishment as essential to their goals. I'm pleased that representatives from many of these groups are here this evening. Your work provides a synergy that will enable wider availability of universal coverage. When The Lancet prepares a series, our involvement does not end with publication. The Lancet is committed to universal health coverage. We believe in its principles and in its potential, and will be revisiting the topic in the future, not only as an advocate, but also to assess the breadth, depth, and quality of coverage. In doing so, the editors look forward to continued engagement with yourselves, so that together we can facilitate the best health outcomes for the greatest number of people. Thank you.
Thank you, Bill. And in addition to the papers that I mentioned, the series, as you will have seen, has a rich complement of comments, commentaries, a wonderful viewpoint by Jeff Sachs. Viewpoint is a technical term in the Lancet, but it's a great article, and he'll tell us, I hope, more about that. As you'll see also, Judith has been a co-author. Julio Frank, who regrets he could not be here this evening. It's a holiday, Yom Kippur. And we have comments there by David Evans, Carissa Etienne, and Robert Martin. So there's a lot there, and I hope you'll enjoy reading it. Now, as we turn to the others in the panel, I'm going to ask Professor Gufram Mukti first, the Vice Minister of Health of Indonesia, who has been an instrumental member in the Joint Learning Network on Universal Health Coverage, a wonderful sharing and kind of self-driven sharing of tips and information and solutions to problems amongst practitioners on the ground in their countries in important positions as the members tackle these issues. And thanks again to Rockefeller. We have worked closely with Professor Mukti and his colleague Atika Adias, one of the co-authors. And Indonesia is breaking new ground that's very helpful for others to hear about. So with that, Professor Mukti, the floor is yours.
Thank you, David. His Excellency, ladies and gentlemen. First, actually, I was almost not got permission to come here because maybe it is value for time. I have to travel almost for 3 days just to speak less than 30 minutes maybe. But of course, then I heard in the meeting there will be, the Director General of WHO, and also, Jack Risa and Julio Frank, in which with Julio Frank, it is almost, I personalized myself because he was the minister, health minister, then to be the dean, but I was the dean, then to be the vice minister, and the opposite way. So, universal health coverage is a major issue, and it was written in the Lancet, and also I heard that time at the World Health Assembly, Margaret Chan encouraged ministers from around the world to debate universal health coverage, and she was really touched. More than 80 countries spoke on the subject in favor of universal health coverage. And I think also we might know that also she said that universal health coverage is the single most powerful concept that public health can offer or has to offer. And of course that when we read the Lancet, it was very good, and the discussion and comments also very nice. But now is my task. The time also I was the academician, I criticized the government, how to do things. But now I have to responsible myself, how to do things. And it is not easy, actually. And it is right. So like David said, actually 90% is the political things. So I, made the evident by myself. And therefore, I would like to add what a comment about the Indonesia. Maybe I'm not sure whether you understand about Indonesia or not, because some people ask me, "Where are you from?" From Indonesia. Oh, Indonesia. Where is Indonesia inside Bali? The question is like that. And I said, no, Bali is just a tiny island inside Indonesia. Yeah. So Indonesia is very active in the debate, and we are now in the process of merging 5 existing schemes into one universal scheme. So one of the scheme is the scheme for the poor and near poor. We call it Jamkesmas. Sometimes very difficult to find the poor and near poor or near rich. It is broad. Because when we say, okay, in your province, you have near poor, and you have poor like this, the number, and then the province, the governor said, no, we have more than that. So they ask more. So of course that user fees, as you mentioned, that can very difficult situation, especially in catastrophic situation, as Margaret Chan mentioned. But now in Indonesia, to be poor sometimes is good, because many people are claiming they are poor. Because if they are poor, they covered universal health coverage, they got rice, they got also cash transfer, so sometimes like that. And now we are aiming that the complete merger can be reached in the January 2014. And why we merge? I think that is again political commitment, as mentioned also in the Lancet, to improve equity and efficiency. So we hope that by doing one single payer, there are many competition between health providers. We will get most efficient, but at the same time trying to make equity better. And again, the political commitment of Indonesian government and the legislative body, because the basic constitution stipulated that every citizen of Indonesia should have the same access to healthcare. So now we're trying to merge, but we have many challenges. First, that we have many stakeholders, and as you know that Indonesia is the 3rd largest democracy country in the world, so consensus is very difficult. The voice sometimes is very different. One, go to the south, one go to the north. And sometimes then people in Indonesia are thinking during the authoritarian, Suharto is better. Because, to go to that direction very easy. Now it's very difficult. But now the problem is that is my task. The challenge of money, of course, not only political commitment, but also, political consensus, but operational. For example, the IT. When we merge, which IT we will use, whether we start from the zero or we will use one we choose among 5 and then improve it. And the most difficult in Indonesia is decentralized government. So central government want now to be single payer, but in local government they have their own initiative insurance schemes. And therefore, we are now anticipate the impact of the merging that I think in the 2014, we hope that 70% of the population will be covered. Now already covered 63%. So 63%, yeah, so 70% will be around 170 million people. It is a huge number of people. And in 2017, will be 90%. In 2019, 100% will be covered. But what does it mean covered if the access health infrastructure is not, cannot compensate? When we introduced in 2015 with the Jamkesmas, the healthcare for the health insurance for the poor, then the hospitalization rate increased 300%. You can imagine. So now almost all hospitals, especially ward class 3, mostly are full. So again, we are leading to this effort, but appreciate the support of many organizations, of course, Rockefeller Foundation, WHO, and the network, especially JLN. As the founding member of the Joint Learning Network for Universal Health Coverage, we have already, the Joint Learning Network has provided us with the new ideas about how to carry out this reform forward. For example, one of our group already visited the Philippines, and then we are trying also to visit Thailand. So among the important stakeholders, sometimes quite difficult to have time and to talk. So because then JLN invited us, the stakeholders in Thailand and also in Mombasa, also in India at the time, so they can talk. So thank you. And of course, that Rockefeller Foundation has helped us in creating this network and growing it to meet our needs. And we hope that the Rockefeller Foundation can stay to help us. And universal health coverage is an iterative process. Of course, Indonesia now would like to achieve within very short period of time. You can imagine the German, the first country in 1887, Otto von Bismarck launched the law, but to reach universal health coverage need around 100 years. And Indonesia now would like to reach it within 5 years. I'm not sure, but I'm optimistic with your support. So again, I think I would like to close my speak. So as the member of Foreign Policy and Global Health Initiative, also mentioned by Margaret Chan, tasked with producing draft of central goal of post-MDGs. So President of Indonesia, one of the key people beside the Prime Minister, UK Prime Minister, and Liberian President to help to develop this vision for the world. So I hope that universal health coverage will be one of the main goals for the post-MDGs beside the sustainable development, or maybe it is this prerequisite for sustainable development. So if everyone here, including the foundation and all of our partners, universal health coverage could become one of the major themes in the future. I think that is all, and thank you very much.
Our next speaker, Jeff Sachs, well known to many here, has been a terrific force for good on many issues, including this one. There are few more effective and compelling voices than his, and so it's terrific, Jeff, to turn the floor over to you.
David, thank you very much. It's a great honor to be on this panel and a real pleasure to be in this issue. I want to thank Bill for that, for the opportunity to add a viewpoint. That's what I did, technically. Good. And to have a chance to reflect on just a few aspects of this issue, mainly with regard to the very poor countries. So my focus in the viewpoint is about the poorest countries and what can be done. But I'll say a few words about the richest countries as well. I think a good starting point is back 64 years with the founding of WHO and with the Universal Declaration of Human Rights. Because both in 1948 put health as a human right. And of course the idea was that not only is health central to well-being and survival, but it is something that we should strive for universality as a result. And we're still trying to implement that, and I think that universal health coverage is an important part of the implementation of an idea that is not only around, but is already part of our international law and our international sense of human rights. Of course, it's 34 years ago since the Alma Ata Declaration, which was yet another very important milestone that called for health for all by the year 2000. And that was a great document and a vivid call, so vivid we remember it still today, it still reverberates. The basic idea there was that not only is health a human right, but it can be delivered by a primary health system. So the Alma Ata Declaration really put the focus on a local health system as a major instrument of delivery. Of course, by the time we reached the year 2000, we did not have health for all. We had 3 massive pandemics underway simultaneously, as well as a lack of basic health coverage for 1 billion people in the utter sense and many more in a quality sense. The pandemics, of course, were the AIDS pandemic that we still struggle with till today. A second was malaria, which had gotten completely out of control because after a failed attempt at eradication, there was a kind of a collapse of normative control and financing, as well as the loss of efficacy of the first-line drug, which was chloroquine at the time. And the third epidemic was TB, partly on the back of the AIDS pandemic and partly through the emergence of multi-drug resistant TB and soon extreme multi-drug resistant TB. So it was not a happy occasion in 2000. I was myself very fortunate to be enabled to step into this complicated and really quite moving situation when Gro Harlem Brundtland asked me to chair a commission that showed her savvy. She said, you know, I was Prime Minister of Norway, but it didn't matter at all if I couldn't convince the finance minister. What good was being Prime Minister? So she asked me, she said, Jeff, could you bring your finance minister friends around and bring together with the public health experts, and let's try to make a marriage of the finance sector and the health sector. And it was, as so often with her, a great call, watching the interactions of these. But I learned a number of things from the public health community, I should say. First, we were able to, I think, show what is replicated in some important papers in this series, that improving health improves development, just as Margaret said so clearly. And so the economic return on top of the obvious human return is really very powerful. And finance ministers need to take note. This is not just a cost center. This is a way that countries develop. Second, we learned, and then I think the Lancet and WHO probably together did as much as any group to really clarify that for the vast majority of conditions killing poor people, especially the excess disease burden of the Category 1 diseases, in other words, communicable diseases, nutrition-related disorders, and childbirth, there were practical, low-cost interventions that could make all the difference of life and death, the difference of quality of life, the difference of healthy life years, and that they didn't cost all that much. And the third point that we made in that work of the Commission was that while they don't cost all that much, they are beyond the means of the poorest countries themselves. And this is a kind of hard paradox to say that on the one hand, it's really cheap to have a basic primary health system in a low-income setting. But on the other hand, it's not quite cheap enough for the poorest countries to pay for on their own. And I try to illustrate this very briefly in this article by noting that most estimates say that one needs at least probably $50 to $60 per person per year in current dollars to manage a very low-cost rural primary health system. You don't get a lot of fancy things that way, but you get safe childbirth, communicable disease control, monitoring of babies, emergency rescue, trauma units, and so forth. And that's a really low cost when you think about the fact that we're paying in the United States in public dollars about $3,500, and in total dollars about $8,000 per person. So the point was that at very low cost you could address this Category 1 disease burden quite substantially. So what is $50? It's too much for a very impoverished country, was the basic point. If you have about a $300 per capita income, $400 like Ethiopia right now, and a country at that level of income can raise about 20% of its national income in domestic revenues. If it's $300 times 20%, it's $60 per person per year of all government revenues. And that has to be used for education, for health, for infrastructure, for the legal system, for public administration, for all the rest. And the norm of Abuja, of course, is that 15% is the stretch goal for health. So if you have $60 per capita in such a country of domestic revenues and use 15% for health, that's $9 per capita. That's not $50 per capita. Turns out, therefore, that for the very poor countries, they can't make the health system work on their own. And it really doesn't matter how you try to grab the money. There's just not enough to really keep people alive, and life expectancy is considerably less than it can and should be because of that gap of $30, $40, $50 per capita. So one of the things that we recommended was a major scaling up of finance for the poorest countries in public health, and we recommended a global fund, for example, which Kofi Annan championed and became the Global Fund to Fight AIDS, TB, and Malaria, and programs like it, PEPFAR and PMI and many other programs. And there has been a significant scaling up of health dollars from international donors for the poorest countries during the last 12 years. Well, lo and behold, the results are really quite spectacular. Things work. What was said a dozen years ago was you couldn't really treat people with AIDS very hard, horrible things were said about all the waste and everything that would be lost and stolen, and I won't repeat all those arguments, but turned out to be completely wrong, of course. Malaria, which is really a difficult disease to control because its basic reproduction rate is sometimes 500 or 1,000 in a holoendemic environment, which means you take off control, it spreads like crazy. But even malaria is down by 40 or 50% in sub-Saharan Africa right now, and I think we can thank the mass distribution of bed nets, the mass access to artemisinin and combination therapies, and more recently, the invention and deployment of rapid diagnostic tests and so forth. Well, in one disease after another, safe childbirth, prevention of mother-to-child transmission, keeping newborns alive in first breath, helping babies breathe protocols. There are a tremendous range of proven protocols that at low cost make a huge difference. And the Lancet has done a world of good and service to have article after article saying, here's the best practice, whether it's maternal survival, whether it's under 5 survival, whether it's neonatal survival, whether it's nutrition, and so forth. And they have documented this class of things to do. So the beauty, therefore, is, and I'll just close at this point, when countries reach maybe $1,500 per capita, which is an increasing share of the world, then out of their own revenues, they can afford to implement a universal health coverage. And they should. And there's, I believe, overwhelming evidence that doing this through public financing has huge benefits for equity and for efficiency, as opposed to the kind of private system that the US has, which is neither equitable nor efficient. In fact, it's grotesquely wasteful because it's private in the way that it's private. This is not something for markets, by the way, public health. This is something for the public sector, and not only for normative reasons, because public health is a system. It's not something that a bunch of disparate competitive units provide. It's something where you have information flows, where you have normative standards, where you have systems of finance and payment and so forth. And so when countries reach a quite modest level of income, first, they can finance universal health coverage themselves. Second, they should out of the public budget. And third, what we see in outcomes is that even pretty low middle income countries are with life expectancy above 70 years and sometimes even 75 years, because you've basically closed that gap at a pretty low level of income. So I think countries like Indonesia should do exactly what you're doing. It's tough, but you'll get there. I have full confidence in that. The remaining challenge, I believe, for us is to help the poorest countries make that lift until they become the low middle income countries, and then they graduate from that first boost and they get to what needs to be done. And we made a calculation a dozen years ago that is still basically true today, which is we need about 0.1% of rich world GNP to close the financing gap for the low-income world. It's about $40 billion a year of development assistance, roughly 1/7 of what's supposed to be the total body of development assistance, to make it possible for even the poorest countries to have standards like 30 per 1,000 under 5 mortality or less, or maternal mortality of 100 per 100,000 or less. In other words, to reach middle income standards, even for very, very poor countries, by implementing a basic health system. So I believe universal health coverage is absolutely within reach. This is a small reach financially. The Global Fund, I believe, should be turned into the Global Health Fund. And I know that Tedros fought hard for that and continues to fight hard for that, because we need a fund that's not 3 vertical programs, but basically putting in place the means for basic primary health delivery, including AIDS, TB, and malaria, but as a basic delivery system. This is not a lot of money. The technologies are sound. We just have to clear a few cobwebs away of misunderstanding, it seems to me. Those include, A, the private sector cannot and should not do this. This is not about the private sector. This is about public systems. Second, it's about public finance. Third, the poorest countries cannot do this on their own, even if they're ideally governed by saints and all the rest, because there isn't enough funding for the very poorest countries, so there needs to be extra. Fourth, the amount extra is really tiny. It's 10 cents out of every $100 of GNP of the rich world. And that is a very, very small amount of money. That's my message as a macroeconomist. That's some Wall Street Christmas bonuses. That $40 billion is less than half of what we waste in Afghanistan each year. It is roughly, what is it? It's about 6% of our defense budget. And it's not that the U.S. should do all of this. This is just to illustrate how preposterously low it is that we agonize. And since there are 1 billion people in the high-income world, even about 1.2 billion at this point, it is about $40 per person in the rich world to save millions of lives per year and help the poorest countries get out of the disease, poor health, poverty trap that afflicts them and thereby afflicts so much of the rest of the world with their problems as well. So I 100% subscribe to the practicality of UHC. I 100% subscribe to it as the right organizing principle. I really thank the Rockefeller Foundation for its stellar leadership in this and continuing leadership for 100 years. Maybe I'll just end by, just short digression. For those of you who are not Rockefeller Foundation, this has been, over the 100 years, the single most important institution in global development of any institution. It runs circles around the World Bank and others in what it's accomplished from the time that it took on hookworm in 1914 till now, and I thank you for continuing that great tradition. Thanks.
Dr. Margaret Chan, Director General of WHO, David, and colleagues, friends. First of all, I would like to express my gratitude and also my thanks for inviting me, the Rockefeller Foundation, to join you. As you know, universal health coverage is dear to my heart, and it's a very important issue to really discuss on regular basis. And I would like also to thank Richard Horton and the Lancet for preparing this very important piece. I saw the soft copy, and I saw now the hard copy. I saw the profile of Margaret in the soft copy, but it's not here. So in the soft copy, no wonder why Margaret is really pro-universal health coverage. Since her young age, she was really up to it. And it was not surprising to me when she passed a very strong message today, and also in all the sessions that we met. In my presentation, I would like to raise maybe a few issues that may help us for the discussion, because there are some elements that sometimes we have some differing opinions on. So the first one I would like to raise is about universal health coverage. we take it as a lump sum. And even in the Lancet series, I think that's how it was presented. But I think it has compartments in it. The compartments are, it's good to divide them into universal primary health care and then the comprehensive primary health care. Because I can give you one example. In Ethiopia, for instance, based on the situation that we have, the major problems are like malaria, HIV, TB, diarrhea, pneumonia, maternal and child ailments, and so on. And after identifying these priorities, we took primary health care at the centerpiece of the health system. And to really work hard on that and to give our communities what we can give today. Because if you lump sum it, then you may really wonder about covering the whole health service coverage, and you may end up not giving even something that you can give to your communities. So that's how we want to approach it. I'm not saying we shouldn't go for comprehensive health coverage, but we should focus on the primary health care part of it based on the prevailing situation. In many countries, developing countries, including Ethiopia, the major health problems were those I outlined. So the focus should be identified. And if the focus is identified, then I'm dead sure that for developing countries, the primary health care would come first. Because to fight communicable diseases and also problems related to maternal health, I think the basic service is really key. So I'm not saying we shouldn't care about the other services like secondary or tertiary, but we should really set our priorities, and we should talk about primary universal health care. That's how we want to address it in Ethiopia, and that's how we see it, without excluding the rest, but identifying the centerpiece and giving more attention to primary health care. And the second issue I would like to raise is, when you talk about primary health care, we believe in our government that primary health care should be free. It's basic, so it should be free. And although it's not like everything free in Ethiopia, but most of the basic services are free, like family planning, immunization, treatment of diarrhea, treatment of pneumonia, treatment of TB, HIV, and other basic services, especially the public health important ones, are free. So that was what we decided from the start. The major part of the primary health care should be free, because Jeff was talking about people who can afford. In developing countries, to be honest, anyone from the rural community wouldn't afford to pay. It would be really painful even if they pay. So in order to really boost the agricultural, the economic development, maybe for some time people cannot be dependent forever, but I think primary health care can be free and should be free, and that's how we started it. And this is, I think, one issue that should be discussed when you talk about primary health care. Okay, you have universal health care coverage, but when you talk about universal health service coverage, it also identifies the finance issue as one of the important elements. Whether you're giving it or not would be known if you address the financing part of it. So this is second. And the third issue is, as what Jeff said, the public sector should take more of the share. We believe in big government, for instance, in Ethiopia, maybe. Unlike in the US, there is some. Of course, there is still that discourse is there, big and small government. In developing countries, I think governments should take more responsibility. And even in the developed countries now, if you go back to history, the governments were big and were involved in many of the drivers of the economy to the level that they have reached now. And if I tell you about Ethiopia, more than 15,000 of health posts were built by the government. Would you, in just 5 to 6 years, would you expect a private sector to do that? Unless it's profitable, they wouldn't do it. And the government built more than 2,300 health centers, which provide basic medical curative services, the 2 lines of primary health care. And who would, in his wildest or her wildest dream, think that the private sector could do this in 6 to 7 years? But by doing this in Ethiopia, many people are now getting access to treatment. And as I said earlier, since the first line, especially the health post-level service, is free, anyone who wants it is getting it, unless when we have some financial or funding constraints, which could be a limiting factor in an economy like ours. So when we talk about health services coverage universal, then in the developing countries, whether the developing countries are using own resources or getting funding from donors, as you know, many of the developing countries are donor dependent for their health expenditure in a big way, I think the government should take ownership. Unless you do that, the speed will not be there, and the impact will not be big, the coverage will not be big. You cannot really scale up. You cannot. And the other element is, it's not because the government is important to increase services fast, but there is another element to why the government or the public sector should be engaged in a big way. In countries like Ethiopia, as I said earlier, the major problems are communicable diseases. And you can address them using health promotion and disease prevention. That means you should educate your communities, you should mobilize them, you should empower them. And without the government, I don't think no single private sector would do that and would have even the capability to do that. Because the whole value of a government and private sector are so different and divergent and sometimes contradictory. So I think for universal health coverage to be achieved, it's very important that we focus on health promotion and disease prevention, and the government has the comparative advantage to educate, mobilize, empower, and have bigger impact. So I think it's crucial that when we talk about universal health coverage, especially in developing countries, the bigger role should be the government's role. Otherwise, I don't think we can achieve what we have achieved in Ethiopia. And it's a gold mine now. We can even achieve more because we're just learning from our experience, but I believe that we can achieve even more. And the other element to it is, in Ethiopia, we don't think that health services should be commercial. It's in itself, it's a right and also a driver of the economy. So because of these 2 things, we want the government to do it. One, it's as a right, it's in the Constitution, so the communities should get their rights, and government should do this. And the second element is, the biggest enemy in developing countries, including Ethiopia, is poverty. And in order to address poverty, I think you have to accelerate economic progress. And for that to happen, you have to really invest on your health, because health is one of the drivers of the economy. And in large scale, I think the government role would be key, especially to keep the health of the labor force to contribute to the economy. So there are many elements to it, but the third issue I wanted to raise was especially the public sector. But then taking you back to where I started, as I said, primary health care coverage and the comprehensive, we should see it in different categories. Of course, it's one, but it's just to set the priority. But as I said earlier, it doesn't mean that we should ignore the rest while focusing on the basic. We can focus on the basic, but we should also plan or increase our investment on the rest of the health coverage as well. And to do this, what we're doing in Ethiopia is we linked it with our bigger country goal. For instance, we're aspiring to achieve the middle-income countries level in 10 years from now. That's the goal for our country that we set. And we're trying to tune the universal health coverage in line with this goal. And we're trying to learn or benchmark countries which are middle income now, like Thailand, Indonesia, Turkey, Brazil. And we're getting support, for instance, from Yale University and Harvard University in planning that. We have already started planning for that. So the issue I would like to raise at the first is, although we should see universal health coverage as two areas, we should approach it in a phased approach. And in addition to that, we can benchmark right now and then link it with our overall development goal of the country and do the planning now and start the steps towards achieving that. And for many of the developing countries, there are many middle-income countries that can be used as a benchmark to have your target right away and do it for the future. So taking change as a constant. So through this approach, we believe in Ethiopia, we can achieve universal health coverage, which is also should be treated as a public good rather than a commercial. And we're building our insurance in order to sustain whatever coverage we get in the future. So we're introducing both social health insurance and community-based health insurance. And in many of the middle-income countries, you see that mechanism. And it will be a mandatory insurance. It's already our law now. And we hope this will speed up the universal coverage. So finally, I would like to thank you for this opportunity again. This is a very important issue, and I think we should continue to dialogue on this. But there are, I think, issues that should be considered when we talk about universal health coverage, be it for developed or those in the middle. Thank you.
We will take a few moments for questions and comments, not too long because people are tired. There are many people here who've had important roles and will going forward. I want to mention again from the Rockefeller Foundation, Heather Grady and Jeanette Vega, who have key roles, and we thank them for this. And a voice who is critical at the outset of all of this, and whose vision guided a lot of it, Ariel Pablos Mendez. And I'd like to ask Ariel if you'd like to say anything. Have we faithfully followed your vision?
Thank you, David. And so it will not be a long speech. As many of you know, I believe in the power of ideas to change the world, especially the ideas that are meant to help people. And I'm very happy that the idea of universal health coverage, which was not an easy sell even for my team initially, has found fertile ground at the Rockefeller Foundation and at the World Health Organization, and now so many other platforms. And as Hillary will recall, the idea was to move this agenda from something that was laudable but unrealistic in developing countries to be indeed feasible and inevitable. And we are certainly, David, moving in that direction. As Jeff pointed out, you need about $50 to buy basic health services per capita. In the year 2000, India was spending $16 per capita, couldn't buy the basic services. ODA, as the Commission called for, was essential. But India's GDP has grown, and with GDP, health expenditure grows, and what I call the economic transition of health is taking place. India now spends $60 per capita. So now, of course, that $60 per capita is not equitably spent, but it wasn't equitably spent when it was $16 either, and it was much worse. But now the challenge is not to give ODA to help buy basic services, but really to help and support the reorganization of their health systems and their financings, because there's a more efficient and equitable way to do it. And universal health coverage does exactly that. So I think that, as you also have heard me say, universal health coverage is not about adding capital. Capital will grow as economics development. It's about reorganizing health financing. And what you can cover at any stage of development, as Dr. Teros pointed out, will be different, and for what is appropriate to the epidemiology, the economics, and the culture of a country. I have to say that it's actually easier when you just reach the $1,000 or $1,500 per capita in GDP, because and you're spending about $50 per capita, because the political and fiscal hurdles only grow over time, as we have found in this country. Most of the countries, 50 countries that have universal health coverage, did it around 5% of their GDP expenditure in health. This country got Medicare and Medicaid at about 4.55% of the GDP. So the 4 to 6% part or window is the right moment for reorganization of their financing. I would like to just thank a few people, if I may. First, David, who has been my mentor as I try to become an economoid, as Julio will say. And I also would like to really acknowledge Oli Fine, my original mentor, who exemplified the commitment to social justice and who has been inspiration for me at Columbia University for over 20 years ago. And of course, many partners in crime. Of course, Heather and Jeanette were already noted here, but also Laurie Garrett and John O'Quick and the Lancet and everybody who has been involved, Gina and so many more. Of course, my bosses, and of course, Margaret was my boss in Geneva, and Judith, who was my boss at Rockefeller. I now work with Robert and others, and my boss is Secretary Clinton and President Obama. It's a great honor to be serving an administration who has also committed to the vision of universal coverage in this country. And I'm very happy that under the vision of the Global Health Initiative, strengthening health systems and the promotion of sustainability will be indeed key. A new office has been established now at USAID for this purpose, and a new 5-year program that will be focused on health financing and governance to support those countries that will be moving in this direction over the next 5 years. So it's a great pleasure to see the Lancet series. Thank you, Bill. Thank you.
There is a mic or two back there if anyone wanted to make a comment. Yes, go ahead. Just tell us who you are.
Hi. I'm quite loud, so...
Okay, just fire away.
Hi, I'm Lori Wen. I'm with Physicians for a National Health Program. I was really glad to hear Dr. Sachs bring up the fact that the U.S. healthcare system is grotesquely wasteful and inefficient and inequitable. And I was really glad to hear Dr. Chen bring up the fact that 70 middle and low-income countries are in conversation with the WHO regarding moving toward a universal single-payer system. So I'd like to briefly draw your attention to the photograph, the cover photograph on this issue. I don't know how many of you know from which event the photograph was taken. I was very excited when I arrived at the registration table and saw it. This was at a Healthcare as a Human Rights rally, protest, and march organized by an official working group of Occupy Wall Street. This was October 26, 2011. And the working group is called Healthcare for the 99%. And the sole mission of that group is to advocate for a universal single-payer system for the U.S. So my question to you all is, I'd love to hear your ideas as to how we can get there, given the fact that it appears that our political system is completely held hostage by the private health insurance and pharmaceutical industries.
So let's collect a few other comments or questions that people might have. Jono, I see you up. Go ahead.
Yeah, actually, that last comment sort of set it up. John O'Quick with Management Sciences for Health. First of all, let me add my congratulations to the Lancet and Rockefeller Foundation and R4D. Really, really inspiring. And this is look through this. It's a very punchy editorial. There are 3 really inspiring commentaries, 3 evidence-based pieces, very, very good, hard core articles on impact politics and some implementation experience. And of course, Jeff Sachs, nobody ever is left wondering what he's thinking. But I'd like to raise actually a question on that kind of relates to the previous commentator. And by the way, the U.S. law is a really good model for other countries. Gina Largo-Messina and I did a blog after the court case, and what was really clear rereading the act was the core of equitable access, an essential package, an essential benefits package. That's language that we couldn't have used a few years ago here, but that's a great model. But a part of that is there's an area that's very political, that's essential for health impact, and that can rapidly threaten the financial viability of UHC programs, on which the issue is almost silent, and that's the pharmaceuticals area. 50% of out-of-pocket spending in poor countries is on pharmaceuticals. 30% of the cost of a service is on pharmaceuticals, and if the benefit is undermanaged, the costs quickly go up. If it's overmanaged, then as with user fees and all, then you don't get the medicines. And we have 2 really good examples. Ghana, in 2006, pharmaceuticals were 25% of the reimbursements. By 2008, they were 50%, and the average cost per prescription had gone up 4-fold. And they were in the black in 2006 and like 23 million in debt by 2008. Thailand, which is a great program, had the same experience. So I fear that people often think of the pharmaceuticals as just another input, but it's a complex policy situation, and if we don't get that conversation going at the same time, we're going to find what the access countries in Europe found, all of the Eastern European countries, eastern part of Eastern European countries coming in, their programs are threatened by the pharmaceutical benefit. So it's a key part of health, but it's a surprisingly blind spot, it seems, in a lot of the writing in this. And Ariel and I had this conversation 4 years ago at Clinton Global Initiative, and I'm still ringing the bell.
Thank you, John. Good point. Yes, go ahead.
Hi, I'm Shannon Kowalski with the International Women's Health Coalition. I think that this idea is very powerful, and I think it's a wonderful idea that we can all get behind. But I worry that it's not the panacea to all of our problems. We know, as Jeff Sachs pointed out in his piece, that the social determinants of health have a major impact on health status, and financing is not the only way to address it. And I also worry about issues of inequity in access. So one thing that is really important, as many have noted, for universal health coverage is a system that people want to use, and a system that is of good quality and meets people's needs. And I hope that as we move forward in the next development phase, that we give attention to both improving the financing, but also improving the quality of services. I think the other thing that we really need to keep in mind is that even in countries where we have universal access to coverage, the poorest and the most marginalized still face significant barriers to access and to care. And that's something that we need to pay adequate attention to as well. In the area of HIV, which is one area that I've worked in for many years and know quite well, we have a really good understanding now that discriminatory laws are one barrier to access, stigma is another barrier to access, and these are the kinds of things that we need to be paying attention to as well. Finally, as my dear friend Greg Gonsalves would say, we need depth as well as breadth in our healthcare systems and the way that we approach intractable health problems. Now, I hope that for post-2015 that universal health coverage is a feature. I hope it's not the only feature, and that we continue to give focus to things that we have already built significant momentum behind, and also pay additional attention to things that we have neglected. So I hope that things like universal access to reproductive health continues to be a feature and something that we aim for. And addressing HIV, TB, malaria, and other infectious diseases continues to be a priority, as well as addressing non-communicable diseases and other areas. But universal health coverage, one, but not the only thing we need to pay attention to.
Thank you very much. And just before, we will go to the back next, but just before that, I know Margaret has given us much more time than we had thought. I want to appreciate that. She has been lifted to new heights during these days as a busy person. So do you have a final comment?
Yes, I'd like to make a couple of comments, not specifically providing answers to your very difficult questions, let's be honest. It is important, these are, the things, the voices that I'm hearing from the countries and from the people. First and foremost, there is no free lunch. Who is paying for what? And who is getting what? So, these are very complex issues. But if indeed the government has equity, fairness, health is a right, get all the principles in place, and you need to find your solutions. WHO is a catalyst. WHO is a knowledge base, sharing with you some of the best practices that you need to find your own solution. It would be wrong to expect WHO to tell you what is right for you. WHO cannot do that, because at the end of the day, health is highly, highly political. And you have seen it in many countries, not just in this one. Now, money has to come from somewhere. Either it's from your pocket, or also from your pocket, but as tax, or as, health insurance. There are multiple ways to find your own solution. That's one point. The second point I want to fully agree with the comment about is not just about coverage alone. But most countries always achieve coverage first and then tackle the quality issue. But they are not mutually exclusive, and both have to go hand in hand. The last comment I want to make is about your anxiety about the post-2015 that MDGs will disappear. HIV, TB, malaria, maternal and child health, family planning, all these are important issues will disappear. This is not what I'm hearing from the countries. Everywhere I go, countries hold very dearly to the health MDGs, and also 1C, which is about nutrition, the importance of waters and sanitation, the importance of partnership in the MDG. Going forward, Minister Tedros, as much as I love you and agree with you on most issues, and I'm not disagreeing with you. You said big government. Maybe this is an equation for Ethiopia, but you look at another country who's now going into big trouble because of big government. You know which one I'm talking about. In Europe, you know which one. I'm sure you know. I don't want to mention the name. But it is important for you to find a solution. But what you said is absolutely correct. Which private practitioner or private sector healthcare providers or private insurance provider would go to Ethiopia villages and provide the basic package? So I think we must look at universal health coverage as a very dynamic process based on the country's philosophy, ideology, sometimes you call it, and your political architecture, and because at the end of the day, you as a voter, your voice has to be heard. And let that voice be heard and decide on your own solutions. But over time, if you look at the developed countries, someone mentioned Germany took 100 years to get it right. I'm not so sure they're not still reforming. And there's no such thing as you finish your job, you stop. In Singapore, which I know quite well because I studied there, Singapore also took more than 20 years to go and over and evolve. We should not see this as a process that you can finish. It is evolving. It is dynamic. And the political drivers and the forces are extremely important. Don't neglect that. Everyone has a say. So who will trump the other guys? I don't know. But to me, WHO, it is important that health is a right. It's enshrined in our Constitution, and it has to be fair, and the needs of the poorest, especially the poorest, and the marginalized, must be addressed. Sorry for all those very broad comments, because we don't have a cookie cutter. A cookie cutter approach would be wrong. We need different solutions and different models. And WHO would be happy to provide information either through North-South, South-South, information technology, knowledge transfer, but it is up to you. I mean, you need to cast and cut out your own future. Sorry I'm not, passing the buck. Not at all. Okay, thank you.
Thank you very much. Thanks for coming also, Margaret. Thank you. We'll take the speakers who are standing now, but that'll have to be it given that we're getting on. And so we'll start with the woman at the back in the beige sweater.
Thank you. My name is Sari Moon. I'm with the Harvard School of Public Health and the Global Health Institute. I had two questions, actually, one for the DG, but I might be able to send it by email, which is one of the recommendations that the Commission on Macroeconomics and Health made was for the establishment of a fund for global public goods, including for research and development for medicines, amounting at the level of 5 to 7... Yes. So what I'm wondering is what can WHO as well as other actors do to ensure the creation of this fund?
This is still very much a process where all the countries in WHO are very keen and interested to find solutions going forward. As a servant to 194 countries, this is a subject I don't have an opinion yet. Sorry to disappoint you. Don't worry, we will find a solution.
Thank you, Margaret.
I'm encouraged to hear that. My second question, I'm glad you stayed for that, was if the $40 billion that Jeffrey Sachs mentioned were all to go to encourage or to support low-income countries in reaching universal coverage. First of all, we don't have that much yet, so we would need to raise more. But clearly that would not be enough, as former speakers have pointed out, that covering that minimum package of care would not be enough. What are the innovative financing mechanisms that would need to be considered to not only achieve universal coverage, but to achieve a greater depth as well as breadth of coverage?
Thank you. We'll collect the remaining questions, and then we'll ask the panelists if they have comments or answers to these questions. Let's go to this gentleman and then back.
My name is Oliver Fine, and I am the immediate past president of Physicians for a National Health Program, a 18,000-member group in this country. And I just wanted to say we were delighted to be invited here tonight because we view you clearly as allies, but it's wonderful that you view us as allies for universal health coverage. And one way, if we could move to that kind of coverage, single-payer coverage in this country, one way that I think we might see it have a ramification and a benefit is, in fact, our ability to get drug prices to be lower if we could negotiate with the drug companies in this country for lower prices. We can't do that now through the Medicare program because it's run through private insurance companies. But I want to really thank you for inviting us. We're here to support you and look forward to a fruitful relationship in the future.
Thank you very much. And to the woman in the back.
Thank you. I'm from the French mission to the United Nations. I do not have a question, but a very brief comment. I would like mainly to thank you for organizing this meeting, for all the presentations and your effort to promote universal health coverage. And we are all the more grateful that we're going to work a lot on this subject in the near future. I take this opportunity to talk about a group which is called Foreign Policy and Global Health, which is composed of Brazil, Indonesia, Norway, Senegal, South Africa, Thailand, and which is coordinated for 2012 by France. And each year we present a resolution at the General Assembly. And for the next session, our goal is to have adopted a resolution on universal health coverage. So we definitely do appreciate your support. Thank you.
Thank you. Go ahead at the back, and then at the front. That'll be the last two questions.
Thanks very much. My name's Eric Friedman from the Yale Institute at Georgetown University. I was wondering just how we can ensure a very rich vision of universal health coverage. In part, we heard certainly questions about the depth of universal health coverage ensuring, for example, that AIDS treatment and more expensive services are included, but also linking universal health coverage to public health interventions, other underlying determinants of health, such as water, sanitation, nutrition, and doing them really as a package of what people should be covered with. And lastly, there's been a lot of great mention of health as a human right, to really put that at the center of universal health coverage, even thinking about the types of what's covered, for example, education of the population on what the right to health is, ensuring access to justice and remedies as part of universal health coverage, removing stigmatizing laws that we know prevent people from actually getting health services, to try and think of that as part of the package of what universal health coverage should entail. Thanks.
Thank you. And the last comment.
Thank you. My name is Kono Mashiro, Director for Global Health Policy Division of Ministry of Foreign Affairs, Japan. Japan congratulated this special issue of Lancet, and I would like to express the commitment of the Japanese government on promotion of universal coverage, and we assure you that close cooperation, especially with Global Health and Foreign Policy Initiative, to the possible UNZR resolution on universal coverage. And the reason is twofold. Firstly, because universal coverage is a good way and essential to escape from a trap of middle-income country, or essential to kind of get inclusive growth. This comes from our own experience of economic development and create a robust middle class peoples. And secondly, it is also good, universal coverage is also good to kind of escape from kind of fallacy of composition. I'm not quite sure what it's a right way to describe the situation, but the situation is where each donor or organization successfully maximizes its own effectiveness, but it does not necessarily fit the real burden of health on the ground. So it is a good way to accept that kind of situation and get the chance for the recipient country of aid for health to get the kind of their own priority setting. And the question might be to the WHO Director General of Hero and Champion and Mantua of Global Health, but she has already left, and I may email to her.
Okay.
Thank you.
Thank you very much. The panelists, you don't have to answer every question. You don't have to even make a comment, but if any of you would like to, feel free. No? Well, I think we had, no, I think we had a very rich discussion, lots of great comments, thank you. And our panelists, our speakers, and we won't attempt to respond to every comment, but I just want to respond to the question whether any of us have any ideas for this country. And I would